I'm Logan Bertino. I'm a PGY3 at the University of South Florida. I'm an integrated IR resident, and we are here today with basically the dream team of pediatric IRs. We have Dr. Rajat, who is going to be kind of running from here on out and kind of discussing with our panelists, and then to kind of go through all our panelists that are going to discuss their different pathways that they took to get to become pediatric IRs. Just to kind of briefly go through everybody's bios, Dr. Bertino is a clinical assistant professor of radiology at NYU Langone Health, and currently serves as the director of Peds IR at NYU Langone Health Hassenfeld Children's Hospital. He did his residency at Emory in Atlanta, and then IR residency at the University of Washington in Seattle, and then returned to Atlanta to do the Peds IR fellowship there at CHOA / Emory. And his primary clinical and research interests include the gamut of pediatric IR, especially vascular malformations, venous thromboembolic disease, lymphatic and thoracic duct disorders, renovascular disease, clinical outcomes, and trainee education. Next up is Dr. Rakesh Ahuja, who just completed his pediatric IR fellowship. He completed his residency and IR residency at Einstein, and just completed his fellowship at Boston Children's and is now at UT Houston. Dr. Jared Green is a board certified radiologist with subspecialty fellowship training in both Peds diagnostic radiology and Peds interventional radiology. Currently in private practice, where he practices primarily pediatric IR, but also covers adult as well as diagnostic Peds and adult. Works primarily out of Joe DiMaggio's Children's Hospital in Hollywood, Florida. And then prior to moving to private practice in May of 2021, he was an assistant professor of radiology at Northwestern and Laurie Children's Hospital, Chicago, where he served as the division head of Peds IR, medical director of the vascular access team, and chairperson of the Fluoro Safety Committee. He's won clinical and teaching accolades and has begrudgingly published in the fields of pediatric interventional and diagnostic radiology. And then Dr. Desai did a 6-year BSMD program via Rensselaer and Albany Medical College Clinical Research Training Program at the NIH. General surgery at Stanford, then transferred to UCSF for diagnostic radiology, made the right choice. Northwestern for the VIR fellowship, which is the older training pathway, as most of us know, and private practice in adult IR for 10 years, then returned to Boston Children's for a pediatric IR fellowship. And he's now faculty at Texas Children, Baylor's College of Medicine for 3 years, and then actually at Phoenix now as the section chief, pediatric IR, and Vice Chief of Radiology Research and Innovation. And then Dr. Annie Gill is a board certified radiologist and associate professor at Emory. And she has earned her certificate of added qualification in the subspecialty of interventional radiology from the American Board of Radiology, specializes in vascular malformations, Peds hepatobiliary interventions, venous thromboembolic disease, thermal ablations in both soft and osseous, soft tissue and osseous tumors. She enjoys mentoring medical students interested in IR, and has helped develop the dedicated pediatric IR fellowship program at Emory. All right. Dr. Gill has also authored more than 30 peer-reviewed publications. Yeah. Okay. And I'm going to, now that we've gone through all that, I'm going to hand this off to Dr. Sean. And I don't think I forgot anybody, right?
Well, you forgot me, but that's not fair because I didn't give you my bio sketch.
You didn't give me your bio sketch. You gave me
Okay.
Yeah, sorry.
That's fine.
I said you were running everything.
Yeah, thanks, Logan. I appreciate that.
Hey, I
Can you
can
see my screen?
introduce him. I know him very
Oh,
well.
yeah, sure. Go ahead. This is pretty informal, so by all means. No, can you see my screen? Yeah, okay, good. Yeah, so I'm Rajat. I just finished my fellowship at Sick Kids. I'll be a clinical assistant professor at UNC doing both adult and pediatric IR. So I got asked to do this IR training pathways webinar by the RFS, and we have a really great panel here that Logan has just introduced with lots of varying backgrounds and training when it comes to IR and pediatric IR. And basically tonight's all about just kind of hearing their anecdotal experiences and some of their perspectives and opinions regarding the training process. So with that, I'll just give a very quick presentation and then we'll do a sort of a round table here. How do I show this? Nope, don't want to do that. This one. Okay. All right, so is this Zoom thing, can you see that, or is that off, not on your screen?
We can see.
Okay, great. So you can see my screen. Okay, great. So I'm assuming most of the people in the audience are, medical students and residents, and you're attending this webinar because you want to learn more about pediatric IR training pathways. And so if you fall into that group of people, which I hope is most, I think this website is probably the best bet to get the most bang for your buck in terms of learning more about pediatric interventional radiology, kind of where it came from, how it started, how to get involved, joining their society, their meetings, and then learning more about the training programs that they have actually categorized with respect to country. So if you go to their website, North America is just one of many different countries or continents that offer training programs. And actually this society was started by pediatric radiologists and adult interventional radiologists who started practicing pediatric interventional radiology procedures. And fast forward tons of years in history, and maybe some of the other people could fill us in on some of the history, but it's now become this very well-known, internationally recognized society, just like the Society for Interventional Radiology, whose main focus is to advance pediatric interventional radiology everywhere from education to meetings to formally creating and offering or advertising fellowship programs. So if you just go to this website, you can learn everything there is to know about pediatric interventional radiology, and then we can, skip this webinar, or you can come back and listen to some of the discussion. But just to break it down into a little bit of a theme, what we hope to cover in this webinar is to talk about the IR residency, talk about what that is, talk about what the pediatric IR fellowship is, and then, talk about what you do with that pediatric IR fellowship, what the jobs are like, or what you should be thinking about in terms of jobs. So really quickly for, students who are on this webinar who may not be fully aware of what the IR residency is, it's a standalone specialty, combined diagnostic and interventional radiology. You do 1 year internship, just like any other procedural specialty. Then you'll do 3 years diagnostic radiology and 2 years interventional radiology. And then in that 2 years of interventional radiology, you'll also do some electives in some IR related rotations or non-IR rotations, mostly in your PGY 5 year, and then in your PGY 6 year, you're doing essentially almost 100% IR. Throughout all these years, you're attending IR clinic. You're also, if you're at the right institution who has pediatric IR experience, you're probably getting some of that during your IR time. But again, that's institution dependent. And then you typically apply for your pediatric IR fellowship in your PGY 5 year. And then what is the pediatric? The IR residency, IR, DR, clinical care of patients, okay? The pediatric IR fellowship, what is that? So if you go to the SPIR website and you peruse all the different training programs, you'll see that in a nutshell, pediatric interventional radiology is offered as a 6-month, 1 year, or greater than 1 year fellowship. Okay, and in that year, you're able to do pediatric radiology if you like, and you're able also to sit for a CAQ and become specialized formally in pediatric radiology if you like. Depending on the program that you go to, there are variable lengths of electives available in IR related or non-IR clinical rotations, but strictly speaking, for 1 year pediatric IR fellowship, you're probably only going to get 1 month of fellowship. And then, as mentioned, the last sort of theme of the job of the talk is, what do you want to do with a pediatric IR fellowship? What type of job are you looking for? Are you looking for an adult and a pediatric IR job? Are you looking for more pediatric IR job? Do you like diagnostic radiology, and is there some level of that that you want to do more than less, so to say? And then, as mentioned or alluded to before, this field started from pediatric radiologists training other, pediatric radiologists and their fellows. And so traditionally, historically, the pediatric IR fellowship has been offered through a pediatric diagnostic radiology fellowship. And I believe that's still the case today. Just a really quick example of what you'll find on the website. This is just one fellowship program that I took from there, but it's really great because it gives you all the quick hits of everything you need to know. You need, who's running the program, what the description is, what type of procedures they're doing, the durations available. Some will strictly tell you if there's just 1 year, some will tell you if it's more than 1 year, some will tell you if there's a 50-50 option available, the amount of call, the type of electives that you might be able to get a chance to do. So in terms of learning the most about the pediatric IR fellowships, I would refer you to that website. I will just say that some of the main considerations, obviously this isn't encompassing everything there is to know about a pediatric IR fellowship, but some of the main considerations is that, you have to adapt to pediatric pathophysiology and diagnostic imaging and imaging safety and the procedures themselves. And, some people may tell you that a lot of the stuff is transferable adult to pediatrics, but some of it isn't, and in a 1 year fellowship, you're expected to do all the same things that you did in an adult fellowship, including the multidisciplinary rounds, presenting imaging if necessary, doing case presentations, journal clubs, stuff like that. Procedures, obviously, you're going to be doing procedures in IR fellowship. If you want to know what type you're doing, again, go back to the website. They'll show you their complete procedure mix. Again, you only really get a couple weeks to a month of elective in a 1 year pediatric IR fellowship. How you're going to use that, you have to use it very wisely, obviously. Most people, in my own personal experience, have decided to do neurointervention. But if you want, depending on the program, there are other diagnostic or non-IR related, rotations or electives that you could do that could, really be useful in your clinical practice. Clinics, what to look forward to is, just like in the adult world, we have our own clinics. They're targeted towards slightly different disease processes, but you're talking about things like vascular anomalies, enteral access clinic, and if you have time or if you're able to organize it through your fellowship, you can potentially attend some IR-related clinics, such as hematology or oncology or transplant medicine. You may be able to see patients who come through IR. And then, so lastly, just in terms of my bio sketch, I did a ESIR residency. It was a diagnostic residency. And then I did the adult IR fellowship. And then I did a pediatric IR fellowship at Sick Kids. Why Sick Kids? I thought it was a great program, very robust. They did the full gamut. So lots of procedures, super busy, all the extra stuff that I really wanted to partake in, being able to attend clinics, doing all these multidisciplinary, presentations, journal clubs, all that exciting stuff. It was just a very well-run program, and it had been for many years. So they had just had all these opportunities created for their fellows. And if I had more time, I would probably do a neurointerventional fellow elective, maybe a fellowship, but that's kind of taking it a stretch far. But I think in 1 year, you're kind of limited, and we can talk a little bit more through the panel. But I think, for me personally, in 1 year, I didn't want to take time away from IR. I got my hands wet a little bit in neurointervention, but I didn't do a formal elective in it. And gosh, if I had more time, especially if it was required, obviously, if it were required, I would do the probably some additional time to get some more diagnostic or some other IR related, either neurointerventional or IR related electives. And then as with most fellowships, you have to produce a manuscript by the end of it. That goes without saying. And then now I'll just kind of, hand it over to some of the other people on the panel. I want to hand it over first to Fred Bertino. I kind of just want him to talk about, his experience, why he chose pediatric IR, why he chose this fellowship program. If he has anything to add about anything of what I've aforementioned in my talk, would you stick around and train a little bit longer to learn some pediatric diagnostic or maybe some other IR related rotations?
Yeah, all really good questions. Thanks for having me, Rajat. It's great panel. So during the introductions, you know that my route toward, pediatric IR was a little bit kind of from one corner of the country back to the other corner of the country and then vice versa. But it was really good because I feel like I got some excellent training at kind of every step of the way. Training in Atlanta was wonderful. I was exposed to a wide variety of pediatric and adult pathology. Started my ESIR training in my PGY 5-year and learned some great adult skill. Went to Washington to really hone that as much as I could, and then came back to train with amazing people in Atlanta. And I'm not just saying that because she's here in the thing, but I was trained by the incomparable Gill, who I love very, very dearly. So hi, Annie, it's good to see you. But when going through the process of deciding Peds IR, it's not something that you're really prone to encounter throughout some of your diagnostic or interventional radiology days unless your hospital is associated with it. And then if you walk around and start talking to, say, established adult IRs who may try to discourage you by saying, oh, pediatric IR is just, it's a boondoggle. It's not really going to help you in any kind of way, shape, or form moving forward. It's a waste of time because you're just relegated to enteric axis and PICC lines. I really have to say that couldn't be further from the truth. We do so many complex procedures. We give such a wonderful quality of life back to so many children. And we think about things that really kind of put us in the forefront of wanting to set people up to be living the best and most close to normal physiologically of a life that they can for as long as they possibly can. And I think that those kinds of missions for what I wanted to do in healthcare really resonated with me and really set me on this path. And I really have zero regrets. I've enjoyed every possible step of the way. I think the question always comes up about, do you go through IR first to achieve a career in pediatric IR, or do you go through a diagnostic route? And there's really not one great answer because I think both pathways have a tremendous benefit from where you're going. Me, obviously a little biased because I went the IR pathway. I felt like I got really good with my hands and learned a lot of great adult procedures. And I think through that pathway, I've been able to take what I've learned in more advanced adult cases and translate that to smaller, patients who are a lot smaller with different physiologies and see if there can be some parallels. And what we found is, I think, a lot of adult IR, nobody wants to experiment on children. It's not a good thing to do. But if we have data from our adult colleagues and our adult bay of literature, we can apply those things and translate them to younger populations and get some really great results out of them with a little bit more confidence, knowing that something has been tried and true before.
Great. Sorry, I was muted there. Thank you so much for that, Fred. That was some really good information. And so now you're at the director position there at NYU right now, right? So what's that like? Is that a lot of responsibility for you, or is it? What can you tell us a little bit about that?
Yeah, I'm indebted to Annie Gill and Matt Hawkins for sponsoring me for such a great position, but it does come with the caveat of being a lot of work and a lot of responsibility. It's an area that the hospital is looking to grow. These opportunities do exist in various parts of the country for people who want to take on a challenge like that. It's a lot of advertisement and a lot of
Great.
kind of sharing the good news about what we can do for young patients and getting them to see the lens through maybe a minimally invasive procedure that can give a lot of benefit to them. But it comes through a lot of advertisement, going to grand rounds, giving everybody in your hospital or your phone number and telling them to text or call you at any moment of the day. it's a lot of being on call all the time because you want to be there to help the kids out. And even giving that cell phone number to parents, which I do in New York City, which some people might think is crazy, but I do. And it has only helped. It has only built trust. It has helped people get to know you and feel comfortable with you taking care of their kids. And I can talk more about that offline, but I want to give other people a chance to share their experiences as well.
That's great. And just really quickly, how many fellows are you taking a year?
Currently, we do not have a pediatric IR fellowship. So
Okay.
this is the first year that pediatric IR is kind of an established practice there. So it's less than 6 months old. So it is in and of itself a newborn.
Great.
But we're getting it there.
That's awesome. Well, congrats, and hopefully we can have you back and do another one of these and learn some more.
Sure.
So with that being said, let's pass it off to Dr. Ahuja, who just came out of a PEDS trauma case. You're welcome to tell us about that or not, or just tell us why you chose PEDS IR and kind of how you landed to where you're at now, and you know, what would you have done differently, if anything at all?
So mine was a very convoluted pathway, but thanks for having me. And I couldn't agree more with Fred. My pathway is also a little bit biased because I went through surgical training. I did that in India. I completed the residency. I came here hoping to become a vascular surgeon. Thankfully, it didn't work out. I tried surgery for 2 more years, did a couple of years of research, and then just fell into radiology because that was the only open spot. But during radiology, IR was the only pathway which I could connect to. And I got transferred into IR-DR residency, which was integrated pathway. So I graduated that in 2021, and 2021-22, I went to Boston Children's to do a 1 year of dedicated PEDS IR training. And the reason I went to Boston Children's is because of the fascination with vascular anomalies and the program where it's basically a 100% IR. Like there is no diagnostic responsibilities. There is no PEDS radiology training or anything. I personally did not want to invest my time in radiology, at least in diagnostic side. I just wanted to do interventional radiology, be it adult or PEDS. So that's why I went through that route. Now I'm an assistant professor at McGowan Medical School at UT Houston. I am doing adult and PEDS practice at the same time. So right now I'm in the hospital where the children's hospital and the adult hospital is under one roof. Even though we have separate PEDS IR angio suites in the children's hospital, and then separate angio suites for adults in the adult hospital, but they are still under one roof. I can walk between them like within like 3 or 4 minutes. So I just did a PEDS trauma case, was a splenic laceration and a renal laceration. We did a proximal splenic embolization, and then renal angiogram, we didn't have to intervene, but we ended up enrolling the patient in a trial. That's one of the trials that we are part of. It's called ELSA. So we just enrolled that patient. So that's the fascination. I mean, I did a TIPS yesterday in an adult patient on an emergency basis, and do traumas all the time. And then any bigger procedure, venous, arterial, one of the cases I just posted on Twitter was the PAD that I did a couple of days back. It was acute on chronic limb ischemia. We did a recanalization, stenting, below the knee interventions, retrograde, antegrade, everything. So this is what I wanted. I wanted a whole gamut from 0-day-old to 99 years old, anything in between. And one of the things I think Fred and me talked about, and actually Fred was the one who brought this idea up, was the transitional medicine. That's the part where I wanted to be his partner, and with he spearheading that. But basically the idea is that when the pediatric patients transfer from being a pediatric patient to an adult hospital, a lot of things go, basically they fall through the cracks. And the treatment paradigms on the adult side are like very different than the pediatric hospitals, right? So, I mean, the way pediatric procedures are done, it's much different than what the adult procedures are done. So me and Fred being in the hospital where adult and peds are at the same place, basically patients can be transferred from the pediatric practice to the adult practice without losing a physician who's basically giving them a longitudinal care. That's basically transitional medicine. That is something that Fred actually taught me, and I think I have hooked onto it, and that's what I want to do.
That's awesome. That sounds like a really exciting idea. And it seems like maybe it's in the nascent stages. It seems like you and Fred have started talking about this, and hopefully we can get you guys back on for the next iteration of this roundtable, and we can see kind of where that the phase 2 for that's going to be. But just on what you said, I completely agree in one respect. 100% IR, that's great. That's a great thing about IR. If you want to do 100% IR, you can do it and you can get away with it. I'm going to differ with you a little bit on the diagnostics. I actually do enjoy the diagnostics. So if there were a job out there where I wasn't doing 100% IR, it wouldn't be the end of the day for me. But that's a great thing about radiology. It's that you appreciate, the DR, the IR as much as you want. And I'm sure there's a job out there for everyone. Ideally. But we'll go on to the next talk. Jared Green is in Florida tonight. He works at Joe DiMaggio Hospital, and he trained in pediatric diagnostic radiology and also trained at Sick Kids for his IR fellowship.
Sorry to interrupt, Dr. Chand and Dr.
Yeah.
Green. I think Dr. Gill had requested that she be able to talk. I think she has a meeting at COG next.
Perfect.
It's okay. I think Jared won't take too long, and I'll just sign on a few minutes.
I'll be brief.
So,
Yeah,
hi,
I
Jared.
gotta be a dad at 6 also, so equally important as the COG, Dr. Gill. I'm kind of like I don't know, I feel like odd man out a little bit. I never really wanted to do IR. I didn't like it in residency. I always felt like it was kind of like too much of like a macho bro atmosphere. And then I did a PEDS fellowship because I always wanted to do pediatric radiology. And during my PEDS fellowship is the first time I ever met a pediatric interventional radiologist. And as soon as I saw the work that they did with children and the vibe, the environment, the level of care, it really turned me onto the specialty. So I called the audible and snuck my way into a PEDS IR fellowship up in Toronto. Before that, I always thought of IR as like a camping trip. Like, it was fun for a weekend, but I didn't want to live in a tent. And here I am. But I think PEDS IR for me feels very different than adult IR. There's a lot of, different than Rakesh, I guess. Like, I'm not, I'm going to get old also, but I'm not as interested in salvaging like a 70-year-old smoker's leg. The kids to me all feel a lot more innocent, and it's very mission driven in PEDS, and that I like about it. I now have sold out and joined a private practice in South Florida, where I do adult IR and work on the patients I wasn't intending to. But my pathway there again was very different. Again, I was like an IR skeptic, I think. But I trained at my residency was at a big institution where the culture of IR was very different than that you see at like our SPIR meetings. And I think the people on this panel are a lot more kind of soulful and thoughtful. And so it's a little bit like I feel like I snuck into this high-end world. But there is value to it, I think, with the pediatric training. I did a year of pediatric diagnostic radiology, which I do feel like it helped me to speak the language a lot of pediatric pathology. I have a recognition of it like Rajat. I also like my diagnostic days. I try not to say it to my diagnostic colleagues, but those are my easy days. I think it'd be tough to do IR for me with full-time. So I do enjoy my diagnostic days. And I think as a career, I know it's popular on like the SIR emails to look for full IR jobs, but a lot of my IR colleagues who are in private practice, which, is the majority of IR jobs out there, people tend to read x-rays as they get older. And, it's like you don't want to wear your lead as much in the grind of what we do, getting called at 2 a.m. for a GI bleed. So there's a lot of things to think about, which I think are probably beyond the scope of the panel. But I think that no matter how you get there, whether it's an adult IR fellowship in PEDS IR, PEDS diagnostic PEDS IR, I think that it's a great career and there's a lot to be excited about.
Hey, maybe I just suck at diagnostics. I don't know.
No, you're good at diagnostics. I'll give you credit for that. But before we let you go, Jared, and hand it off to Dr. Gill, I just real quick on students or residents who are watching this and thinking, I want to maybe do a split 6-month IR DR year, or I want to do a full IR year and stick around and do a little bit more DR so I can get that CAQ. And is that a big benefit, would you say? Or
Yeah, I think it's nice, again, and I feel like I've talked to people informally at this panel about it. an adult IR fellowship is the way to go. Like the way I went, and there's a lot of extra training that I had to do, a lot of kind of moonlighting nights and weekends to get the catheter skills, the onc work. I still call Annie about venous work. There's a lot of stuff, even though I went to an amazing Peds IR fellowship. There's a lot of stuff that you just see 5 times a day in adult cases that you don't see in kids as much. But I'm not on here to say that everybody should just do Peds diagnostic Peds IR. However, I do think it's really nice to have the Peds diagnostic experience. There's a lot of jobs out there that can't offer you full Peds IR. If you want to do full-time Peds IR, you're really going to be at a large academic children's hospital. And I was really looking forward to leaving that because it wasn't my personality. I said in my bio that I begrudgingly published papers while I was there. I'm happy to be out of the academic world. I'm even more happy for my friends that are still in it because I read all their articles. But I think that if you have the diagnostic experience and you have a Peds CAQ, it's really valuable. It's going to really open doors for you as far as jobs go. I think at this point, to people who are listening in your career, like that if you're an academic person or not. I was always kind of pretending, and now I feel like I'm like a private practice out of the closet a little bit. But it's really helpful to have the flexibility, I think, on jobs. If you wanna be able to live where you want to live, it's nice to have a little more options. And if you find that after you have the CAQ, you're never using it, just stop doing your MOC stuff. But I think if it's not hard to get it, I would definitely pursue it.
All right, great. That's a couple of good points by you. So there are 100% Peds jobs out there, IR jobs, but there are not a ton of them. So you may not land one if you really want one. And getting that CAQ can be really helpful, especially later on if you want to slow down a bit and not do so much IR. Great. So with that, we'll pass it off to Dr. Gill.
Thanks, Jared and Fred. You guys are entirely too kind. But I agree with you that Peds IR is definitely the most splendiferous practice that is out there. And I love Peds patients. I do have just like a couple of slides about oops, I can't share my screen. It says, cannot start screen sharing while the other participant is sharing.
I'm going to stop sharing. So that should give you the opportunity.
Yep, I just have a couple of slides similar to what they showed about the online forum that you can see on the SPIR website. These are just some quick slides about what you would be looking for when you're looking at a Peds IR training job. I am the fellowship director in Atlanta, so I kind of have to have this information ready and available at all times if people ask me about it. And so our IR team has 4 completely 100% Peds IR attendings, which is an anomaly. I do think that this is not true throughout the country. I know the practice at CHOP, I know some of the other practices at Phoenix, for example, they do diagnostic work as well as IR work. And so, but there are some practices that are 100% Peds IR, like the one in Seattle or the one at Stanford or the one here at CHOA. And so you just need to look for what you want as far as training. And all of us have completed adult IR fellowships as well as Peds IR training. We have 2 APPs, which can make a big difference in a fellow's life. When I did my IR fellowship, we had 0 APPs because sometimes—
Sorry, Dr. Gill, we're not seeing your slides. Or do you want to, are you?
I'm sharing them.
Can you guys see her slides?
I could see it, they just weren't advancing.
Oh, they weren't advancing, right? Yeah.
Yep, they're visible.
Can you see this?
Maybe if you just click the second slide.
I did. Can you see this?
I can see the first slide.
Just the first one.
Oh my God. Okay.
There we go. Yeah, we can see it now.
Okay. Sorry, it's like my biggest pet peeve when there's Zoom problems after going through COVID. I feel like all of us should have a PhD. Can you see this now as I'm advancing?
Yes.
Okay. And so I think sometimes the lines get blurred between APPs and fellows. So that is an important thing when you are looking at a program, is to know like how many APPs, what their roles are, how that differs from the fellow. At our practice, we have one physician assistant that is going to start doing very straightforward procedures such as GJ tube exchanges or very straightforward lumbar punctures, but no central venous access. But you know, that is a thing to know. We have 3 IR suites split between 2 hospitals, and we have 1 Peds IR fellow. This is our group. Okay, and so one big thing about our program is that we actually require adult IR training before starting your Peds IR fellowship. And it's just to, you know, Jared's point, is that we feel strongly that you need to really have honed those catheter skills, getting access into vessels before you start doing it on kids, because there are some slight differences, but as Fred well knows, I will scrub in with you starting on July 1st, and I will keep scrubbing with you until June 30th. And that's because you never really know exactly what's going to happen in a case. Just this last 2 months ago, I had a wire break on me in the right atrium of the heart that I've done this procedure a million times. And for whatever reason, it completely broke off in the right heart, and I was trying to snare a wire fragment. So you never know. Applications are reviewed in the fall. We do online virtual interviews. There's one of our procedure suites. We use a lot of cone beam CT in our fellowship, so that's another thing to look at, is what your modalities are that you're going to be working with. And so we're a little bit different in the curriculum than what's been mentioned. So we have 9 months of dedicated Peds IR clinical work, 1 month of a clinical elective. Fred did a really great elective that I think was probably the best choice that someone's had thus far, with the thrombosis clinic. So learning about how to better prescribe anticoagulation and working with our venous occlusions and all of those difficult types of patients that come in with DVTs. We also offer 2 months of diagnostic pediatric radiology, because we do think it's important for people to know protocols and how to help guide them as they go forward into their practice and what they're going to be asking for their diagnostic radiologist to read. We have no adult IR electives built into our fellowship, because again, we feel that that should be addressed before you come to us. And then we have dedicated clinic time for a multidisciplinary vascular anomalies clinic that happens once a week, as well as separate IR clinic. And then these are our procedure numbers. Like I said, I have to keep these updated as we go every year so that they're accurate. And just be a little bit wary on the SPIR website. Like, I don't know how much those numbers are updated. And that's it.
Great. Thank you so much, Dr. Gill. It was a really great presentation. I know you have to go now. You have a call with the oncology group, but maybe just one question before you get going. From the audience here, so there's a resident, it's in a non-ESIR program. They want to do pediatric IR. Would you recommend them to do, I know it's a hard question for your program because they have to have adult IR experience, but would you recommend a DR fellowship or an adult IR independent residency? It sounds like you would recommend the residency.
I would, yeah, okay. I would.
Great. And how are your fellows, creating the most of their opportunity there in terms of, learning the clinical work and the diagnostic radiology outside of their elective time? Do they, lead the imaging for tumor board or surgery case presentations or anything like that, or?
No.
Okay.
No, I mean, for every case, I expect the fellows to have gone over the MRI. Like Fred can tell you. I mean, we'd walk into a case and I'd be like, okay, so where do you plan on treating? And Fred always had, he was a phenomenal fellow. He always knew everything that I was already thinking by the time we walked into the case. But, we discuss imaging when we get the consult for the case. We often walk back into the reading room and talk with the radiologist there if we disagree with a read or if we have a question about something. We review imaging with, we have several clinicians that come down to our IR suite or our offices, and, we allow the fellows to discuss imaging with them there. I don't feel like we don't have a paucity of imaging discussions. It's just we're a really busy clinical practice, and our definite focus is on the clinical practice of IR.
Gotcha. And
I will chime in, and I'll just say is in addition to that too, during the 2 months of diagnostic elective at CHOA, I would go to trauma conferences, tumor boards, surgery conferences in the morning on the various days of the week, and then be responsible for not only reviewing the diagnostic imaging, but also offering an interventional option if one existed for cases. So there is the option to go to those things during the diagnostic electives.
that's really awesome. Fred, you just sounded like the greatest fellow ever, like just all around awesome consultant IR, which you were. I just wish I had a chance.
Is there a question about that?
Okay. As it's easy to be a good fellow when there's no one to compare against because it's an N of 1, so that's fine.
Great. Well, Dr. Gill, I guess I'll let you go if you need to go. So I guess bottom line is 6 months too short for IR. If they do 6 months DR, 6 months IR. Okay, great, perfect.
I think so.
All right, so we'll pass it off. Yeah, thanks, Dr. Gill. See you next time. We'll do this again.
Okay.
Last but not least, we have Dr. Desai from Phoenix Children.
Good evening. So sorry to be the last one keeping you between dinner or whatever else you need to do to clean up the evening. I think most of kind of the global premise of this has already been touched on in some ways. So I thought maybe I'd just sort of spitball some of the things that I've learned, and you'll notice that I have a lot grayer hair than anybody else on the panel, actually. So I've been at this game for a while now, and I still got you beat, Rocky. Not even close. I will also say that for November, I grew my beard out. My kids thought I was training to be a mall Santa Claus. So it's gone white. So look, this is great. We did a panel here at Phoenix Children's a couple weeks ago for medical students as well from the local schools in the area. And a lot of the questions that are being asked are very similar to the ones posed here. I think I want to sort of remind people that the specialty of pediatric IR is a little bit more nascent than the adult interventional world that most of you will be exposed to, both as students and as trainees. And I tell people, we're probably about a decade behind. There's a lot of variability in practice environments, how practices are set up. Do they have APPs? Do they not have APPs? Are they clinically oriented? Do they still take in orders, or do they come in as consults? I think a lot of that is an evolution, and you heard that from some of the early comments where these practices are now being driven in a more clinical direction with dedicated oversight over attention, as well as verbal outreach and participation in the conferences. And for those of you that are as old as I am, you'll know and you'll hear remnants of what it was like to start an adult IR practice 20, 30 years ago. It was very much the same phenomena. And no matter where you end up, I think one pearl that's worth always keeping in mind is that if you're not having a seat at the table, it's probably because you're on the menu. And that was something that was posed to me when I was a trainee. And the bottom line there is that we need to have a voice and representation in all of these different areas. So whether it's the vascular anomalies clinic or tumor board or anything else, they're not going to consult you or call you unless they know who you are and have some reasonable feel or trust of your skills and judgment, which then brings me to the next point, which is I really do think that pediatric IR, and again, I have a bias. I came through an adult or vascular IR pathway rather than a PEDS diagnostic pathway. I think as we see on the adult side, pediatric IR, I think with time will also evolve to be more 100% practice, which is, the practitioners involved in pediatric IR will devote higher and higher levels of time to that practice environment. I don't know that we'll ever get to 100%, which is everybody everywhere is doing 100% PEDS IR. I don't think that that's feasible. And as we've heard, there are others that do appreciate their time on the diagnostic side. So it gives them a break. It's a bit of a different mental challenge, et cetera. But I do think that you'll find that the demands of the specialty and the need for growth will lean in that direction. Very much the same way that now we have, IR/DR residencies as opposed to just diagnostic pathways. So I think that there are good nuggets and lessons to learn from those adult experiences, or what I call the adult experiences. We at Children's, I think, very much focus on this role at Phoenix Children's, very much focus on this role of growth and development. And so we do take in trainees that have come through the PEDS diagnostic pathway or the adult, either the IR/DR or the ESIR, whichever pathways they come in through. And we do offer them the option of having a couple extra months of adult IR at, we have partner facilities at the Mayo Clinic, as well as University of Arizona. And we offer them a couple months of there. And it's not because I necessarily want them to learn wire and catheter skills. It's more so to get that exposure to high level, high acuity cases and learning how to get out of trouble. And I think that is the real drawback of spending time in pediatric IR, is we just don't get as much exposure to high level complications. So as mentioned earlier, if you're doing an urgent tips on a bleeder at 3 o'clock in the morning, that is a real different skill set than putting in a PICC line on a healthy 13-year-old at 2 in the afternoon. I mean, your mind and your body are just operating in different manners and mechanisms. And so we value the training components where they learn how to evaluate cases, and again, how do you troubleshoot cases as they start to go south. That's part of the reason that I bias towards coming in through the traditional IR pathway. And that is because you just get more exposure and you get more patient knowledge, as well as growth and development on the clinical side. I think from a PEDS diagnostic standpoint, I don't want to diminish the skills of my diagnostic colleagues, but a lot of that we pick up along the way, either evaluating cases or as a trainee as you're going through your pediatric months. And so I feel less inclined to say that PEDS diagnostic is kind of the pathway that will be dominant. I really do feel, again, my bias, that the IR training pathways will start to predominate as with the growth of the PEDS IR specialty. We are at Phoenix Children's a freestanding pediatric facility. That, I think, is different from some of the environments that we've heard of, either at NYU or Lurie or Emory, or even Sick Kids. We don't house an adult partner under our roof. And so we do have partnerships with Mayo and University of Arizona, but we are alone in the sense of, how do we run our practice, who provides oversight, et cetera. And that, I think, is really valuable to us because it allows a certain amount of autonomy and decision-making that we're not, beholden to a separate entity for. And so this has actually been kind of my favorite practice environment, if you will. I did, as mentioned earlier, adult IR for about a decade in private practice, where we would do cases 15 to 20 a day, as well as help out on the stacks, although that word doesn't have as much meaning anymore either. So, those were busy days. And we had no research components to it. We didn't write anything, obviously. Now I do a lot of different things. We go to conferences, we're involved in clinical workup and development of a care plan. There's many times that we say no to things and we send them somewhere else, and that's part of the relationship building that our adult colleagues have spent a lot of time in and developed, and I think we also will benefit from. I do want to answer or address a point that was made earlier. Pediatric IR is a non-ACGME accredited fellowship. For anyone that comes into the specialty, it's well advised that, or it's mandatory that you sort of do something ahead of it. Again, the options now have expanded a little bit, but it will not count towards for FMG training or anything like that. It is a ACGME fellowship. At our institution, we do tend to follow the ACGME rules because it all falls under a singular graduate medical education umbrella. But it's not going to count towards anything other than just when you apply to PEDS IR positions. There's no certification pathway as yet, although that's been discussed. So we really, when we look at job applicant candidates, we really do look at the clinical acumen over their diagnostic abilities. And although we don't mandate the pathway be an IR training pathway, it is something that again, we value. And so thanks for allowing me to sort of voice my opinions on the panel. It was fun listening to everybody else and hearing sort of their own individual experiences and comparing it to mine. But I'll turn it over to Logan and Rajat, and we'll go from there.
Yeah, great. Let's see here. Can you hear me? Yeah, great. Thanks, Dr. Desai. That was really great. Yeah, big takeaway is, in small kids, you can be in very precarious and dangerous situations. And I guess early in your practice, you don't want to be in a situation where you can't lean on somebody or not know what to do. So it's a completely different ball game, I guess, when you get to pediatric patients. And then in line with some of the things that we've been talking about before, every program is a little bit different in terms of what they offer you in terms of diagnostic training and clinical training. So it's really worthwhile going on the SPR website and, perusing through some of the programs and even contacting some of the heads of the department at the programs if you want to learn more and maybe set up a rotation for yourself. But I guess I'll ask you, Dr. Desai, have you ever heard of anything called private practice pediatric IR or outpatient pediatric IR? Does that exist yet, or are we on the way there?
It's probably a better question for Jared, I would think. So in my experience, so when I did private practice, we don't discriminate based on age, right? So whoever rolls through the hospital environment, you're going to take care of. And Fred's nodding his head. It's the same at most facilities. And so I think when we talk about the development, and this is probably the crux of what this panel represents, when we talk about the development of pediatric IR, what we're moving away from are practitioners that are adult IR practitioners that do PEDS IR cases because it's part of the package that sits in front of them. What we're moving towards are dedicated practitioners who spend the vast majority of their time on pediatric IR patients. So whether that is in private practice, I think it will grow and develop again, just like adult IR started in the university practices and morphed into the community and now has become indispensable. I think we will see a similar outreach of pediatric IR into these environments. But again, I'm sure Jared has some thoughts on that. I want to add one thing though before Jared hops in, which is it should be clear that being a pediatric interventional radiologist is just because you like kids doesn't mean that PEDS IR will be good for you. And that was sort of a lesson that I had to learn, which is I love taking care of kids. I love that we can make them better. And as was noted, they're innocent and the vast majority, I have yet to deal with a 60-pack year pediatric patient. So, but in my adult practice, right, they were a dime a dozen. But you really got to be willing to deal with parents and families to get to that end point. And I think that in the adult world, it was much different because you're speaking to and communicating with patients that are then responsible for their own judgments and decisions. Whereas here you're talking to, for the vast majority of time, the parents of patients that you're then responsible of taking care of. So getting them to an endpoint is wonderful, but you got to be able to interact with the families in so as much as, you know, the children, and knowing how to take care of them. So anyway, just a thought.
Great. Any last words there, Dr. Green?
Yeah, I don't know if it was from the chat or just your question, Rajat, for the group, but there are, I mean, I'm in private practice now as a Peds IR. It's a big group. It's about 60, 65 radiologists. I don't know the recent number, but they needed a Peds IR to check a box basically for US News for the children's hospital that we cover. That was the genesis of my being hired, and I think that since you know, and I did get a lot of pushback from the group, as Sudhen was saying, you know, they were doing fine without me. They were putting the drains in and stuff like that, right? The adult IR guys were doing the kids' cases. But now with me, they have somebody that talked an 8-year-old into getting her dialysis line removed with just local. It was a fresh line for the other IRs. It was a fresh line that was infected. But talking an 8-year-old and just letting me slide it out at the bedside, spending an hour doing that, right? I mean, which there's not an adult IR in my group that would have done that, but it was the right thing for the kid. She didn't need to go to sleep. The line was going to fall right out. The hardest part is taking the dressing off. But this is kind of, I think, what you're signing up for if you want to do Peds IR, that you really have to want to take the time to do things like that, to put the patient first. I mean, obviously, the easiest thing for me in the world is to walk in a room with a sleeping patient. But we don't always, you know, we make the choice that's best for the patient, not for us. As far as the private practice academics thing, you know, I'm a little bit of a cynic, and I'm making fun a little bit about the academic job that I left. It was an amazing job. I was doing better cases than I am now, but I am actually really pleased with the cases that I have gotten to build in a private practice setting. I cover full Peds IR 3 days a week. I do a day of adult IR and a day of Peds diagnostic. No matter what I'm assigned to, whether I'm diagnostic or adult IR, if there's a Peds case, I do it. The practice is really committed to the growth of my service. I'm opening my new Peds IR biplane room in January. So I'm in a really, really good situation professionally now, I think. Obviously, there's a lot of days that I miss. I'm sure if you look at basically anybody else in the panel, like their case list from today, it's probably like what I do in a week or a month. So, you know, there's good and bad with it, but you know, the private practice model was really good for me at this point in my career. It was invaluable for me to be at Northwestern at Lurie Children's for 7 years, fresh out of training. Like I said, I did only a Peds IR fellowship, so there's a lot of extra training that I learned on the job. To Sudhen's point, also the acuity of the kids that I'm seeing now in my hospital. You know, if a kid gets hit by a car, they don't decide to go to Boston or Northwestern, they go to the closest trauma center. So I do see sick kids, but not on the same level that I was seeing. You know, I'm not at a transplant center. So there's just a lot of, I guess, the high-end cases, the really sick kids, the medically complex kids that I'm not seeing. And I think it would have been a disservice to me professionally to take a job like this directly out of fellowship with my training. So I feel really lucky for the way that I went. You know, whenever I meet people who are in the audience situation, I tell them, you know, kind of, I don't know that I would repeat my training pathway if I could do it again. You know, if I were to win the lottery, I don't know if I would go back to being an adult IR fellow because it sounds terrible. But the training that adult IR fellows get is definitely superior. Hi, baby. Sorry, I'm in my house. My kid, stay out, baby. Is superior to what I got as a Peds IR fellow. But like I said before, overall, whether you decide to go academic, private, there's always going to be a home for you, and it's a very in-demand job.
Great, that's awesome. Well, I think that might be a good place to end. If you guys can see my screen here, Again, that's the SPIR website. If anyone has any questions, I was just kind of perusing the audience, mostly students and residents. If you guys have any questions at all, please feel free to email me. I can get in touch with any of these people on this panel as well. If you want to speak to any of them, I can forward any questions to them as well. And again, this is recorded, so it's available if you want to check it out at any other point. Any other last pressing thoughts or
Yeah, Rajat,
opinions?
there was one
we can discuss
thing in the Q&A.
Oh, yeah.
And there's a couple questions about how to kind of prep for DRIR. I think, any residency is kind of the same, which are, you want to get to know the people at your institution that are in charge of it. You want to get good recommendations letter. You certainly don't want to fail the rotation. Any research that you do in the space will be useful. But the last one was the one that caught my attention, which is someone applying for IRDR and didn't get quite a supportive response, saying that they'd like to do a subsequent PEDS IR fellowship. I don't know that that would be a prevailing mentality. I think most program directors will be open to the idea of people wanting to go into pediatric IR. It's a well-known need. So I would probably disagree with the perspective that you were communicated. But with that said, again, it's a bit of a nascent field, and so people will say, well, you just need to do the adult training, and then that's enough to kind of convey to the pediatric side. But I would say that a host of doors open once you do a dedicated PEDS IR fellowship.
Yeah, I would agree. No, just in my own anecdotal experiences, I ran into a bunch of people that told me a lot of different things about you name it in radiology, and the light really shines when you start going on these websites, attending these meetings, meeting more people, networking, kind of figuring out what the field is really like, just gathering information on your own. But yeah, that's my only two cents.
And just so folks know, at the annual SPIR meeting, there usually is kind of a trainee carve-out group. And so you get a chance to talk to other program directors and stuff like that to communicate some of this.
Great. Yeah, I'm just looking at these questions right now. The last one's pretty interesting, about doing a PEDS internship instead of medicine or surgery. I actually didn't see that until now. So that's actually an interesting route. I did that route. I did a PEDS internship, but that's only because between medical school and residency, I had some extra experience, clinical rotation experience in internal medicine and surgery. So I felt like I had that in terms of internship experience under my belt, so to say. But I did a PEDS internship, and the only reason I did it was because I got dedicated time in ICU and surgery, and I think it was really helpful. And if you want to talk to me about it, we can talk. You can just email me, and I'll talk your ear off on it. But kind of my major thing about that is, if you're going to do an internship, do surgery or medicine, especially if you haven't had that experience prior to doing internship. If it's only been in medical school rotations, that's not enough. That's not an internship. All right, great. So that wraps it up. If anyone else has any last pressing thoughts, now's the time. Otherwise, it's been great. It looks like there's three of us panelists who have survived till now. I had a lot of fun. Thanks guys for coming. Hopefully we can do it again and maybe get some other fresh or recycle some faces, and hopefully get more of an audience next time and talk about whatever.
Yeah. From like kind of an audience perspective, that was amazing. All the advice and everything, all the different perspectives that you brought to the table was fantastic. So thank you all so much.
Thanks for having us.
Thanks for having us. Have a good evening.
Thanks, guys. Good night.
All right. Bye, everybody.